Yes, thank you very much. It's a pleasure to be here. And before I start my talk, I will only take 10 seconds to thank Dr. Sakis very much for including the European Society of Cardiology in this meeting. I'm here as a representative of the ESC board. It's a pleasure to be here. The ESC is very happy that we can support these meetings, and I would like to congratulate you on the quality and the excellent organization and scientific level of this meeting. So thank you very much on behalf of the ESC. And now let's go to the talk. We have already heard from previous talks that planning is essential in making the TAVI procedure as successful as possible, and CT is used a lot for this planning procedure. And the question is, why are we using CT? Why is it that CT is so attractive? And to understand why CT is particularly useful, let me briefly explain what most of you probably know, that modern CT systems have become very good. They can acquire approximately 300 very thin slices that cover the volume of the heart in a few seconds. The temporal resolution of a single image is typically approximately 100 milliseconds, so you can freeze the motion of the heart and show it without any motion blurring. And in addition, the in-plane resolution is very high, approximately 0.5 millimeters, so you get in the axial slices that were acquired very, very sharp and clear visualization of cardiac anatomy, coronary artery, aortic valve, mitral valve, just as an example. In addition, the slices are extremely thin. They are approximately 0.5 millimeter thin, and this makes it possible to reconstruct images in other orientations and to recreate planes in any desired orientation that you want. And because the slices are so thin, the reconstructed images have the same spatial resolution as images that were acquired in the original axial plane. This is what we call isotropic. The spatial resolution of the CT dataset is isotropic, so we can slice data in any orientation that we want and retain full spatial resolution. That's different from any other imaging modality that we have. MR, for example, good in-plane resolution, poor through-plane resolution. 3D echocardiography has lower resolution than CT, and normal echocardiography doesn't give you this option at all. So this is the advantage of CT. In addition to being isotropic, we can cover a very large volume in a short time, but as I said previously, the main advantage is that we can slice our data in any orientation and, for example, align the image very accurately with the aortic annulus plane and have full spatial resolution so that we can make our measurements. In the context of TAVI, this is used to assess 3 different points that help with planning the procedure. First of all, vascular access. Are the femoral arteries suitable to accommodate the sheath? Second, looking at the aortic root geometry and dimensions, choosing the right prosthesis for the patient. And finally, angulation, which is the best orientation to have the C-arm projection during the procedure. This can be predicted by CT. And let me go through these 3 points that are important for TAVI planning. First of all, vascular access. Obviously, we're looking at the size of the lumen, and depending on the prosthesis that you want to implant, there are different levels for the minimum size that is required. For example, for an Edwards Sapien 3 23 millimeter valve, you need at least 5.5 millimeters of lumen diameter. For the 29 millimeter valve, you need at least 6 millimeters of lumen diameter. I have to say that if the vessel is not calcified, somewhat smaller lumina are also acceptable, and we sometimes do balloon angioplasty to dilate the artery to accommodate the sheath. But lumen size is one important aspect that can be exactly measured by CT. The second aspect is tortuosity. Tortuosity can be problematic when the vessel is calcified. Here you can see a calcified 90-degree angle. And here you can see the problem that ensues, and now the video doesn't seem to be running anymore. I'll try it again. If there's a calcified angle, sometimes the sheath will get stuck and you cannot straighten the vessel. And this is something that you have to be aware of, so you have to look at the combination of calcification and tortuosity, because this is a potential problem. Vessels that are tortuous and have no calcium are absolutely no problem. They will straighten when you put in a stiff wire. That's not problematic. It's just a combination of calcified tortuosity that can be an obstacle to the transfemoral approach. The second area, as I said, is looking at the aortic root, our target region, to determine the geometry and the dimensions. As I said, with CT, you can generate, with a little bit of practice, an imaging plane that is exactly aligned with the aortic annulus, showing the lowest points of the right coronary cusp, the non-coronary cusp, and the left coronary cusp, and this tells you that you are exactly aligned with the aortic annulus. And that's an image that no other imaging modality can give you. And based on this plane that was created, you can create other orthogonal orientations to perform the measurements that are necessary. And one important aspect is the distance of the coronary ostia from the aortic annulus plane. Because as you can imagine, if that distance is too short and the cusp has to go somewhere when the prosthesis is implanted, if the distance is too short, there's a potential danger that the left main ostium or the right coronary artery ostium might be obstructed by the displaced cusp as the prosthesis is moved in. However, you have to be aware that it's not just this distance here that is important. 6 millimeters is relatively short. Here's a case where the distance is relatively long, 14 millimeters. So a TAVI procedure was performed in this patient, and you might be able to see what happened here. After the TAVI prosthesis went in, there's a subtotal stenosis of the left main coronary ostium because there's a big piece of calcification that was moved upwards and obstructed the left main coronary ostium. This can be treated by stent implantation, but in CT you can very obviously see the reason. This distance here is 14 millimeters, but the cusp is 16 millimeters long, and if you flip this upwards, in addition to the large chunk of calcium sitting on the valve, this is what causes the obstruction. So you have to study the CT scan very, very thoroughly to identify patients where this can be problematic. So you have to look at the ostium height, you have to look at the length of the cusp, the depth of the aortic sinus of Valsalva, and the volume of calcium on the valve to identify patients where this is problematic. And about 3 to 5% of patients, there's a high risk of coronary obstruction and this procedure cannot be performed. There's one situation where it is currently perceived as completely not problematic, and that's the valve-in-valve situation. And naively, you would think, what is easier than placing a prosthesis, the transcatheter prosthesis, into a bioprosthetic valve that is already in place? It seems very straightforward and very easy, and in many cases, as you can see on the left, this works very nicely. However, you have to be aware that there's a high risk of coronary obstruction in this situation because many bioprosthetic valves are placed relatively close to the left main coronary ostium, which you can see on the right-hand side. This is a different patient. He has a bioprosthetic valve which has failed and needs replacement. And in this case, you can see that the bioprosthetic valve is so close to the left main ostium. If you place a prosthesis in here and you flip this cusp upwards, it will obstruct the entry to the left main coronary artery, and this patient will have massive problems during the procedure. And it has been shown that in up to 6% of patients, even for the valve-in-valve procedure, coronary obstruction can occur because the bioprosthetic surgical valves are often very close to the left main ostium, and you have to look at the CT scan very thoroughly to identify this problem ahead of time because these patients cannot be treated with transcatheter implantation. So even for valve-in-valve, and more so than for native arteries, coronary obstruction is a potential problem. The second aspect about looking at the aortic root obviously is sizing, given the fact that we can very nicely align our images with the aortic annulus, we can very accurately measure, and depending on the prosthesis that is implanted, we either look at the area of the aortic annulus or at the circumference of the aortic annulus, depending on the manufacturer, and then you can choose the prosthesis size. CT is very useful for prosthesis sizing. What we want to avoid, the speakers before me have already indicated that this is the problem that we want to avoid, a prosthesis that is too small and aortic regurgitation happens. And it has been shown that if you use CT for sizing, as opposed to echo for sizing, the incidence of more than mild regurgitation is significantly lower. It was 5% if CT was used for sizing, but 13% if echo was used for sizing in this trial, which was published about 4 years ago. And there's a very recent trial that compared 3D TEE to CT for prosthesis sizing, and it showed that you could choose a significantly higher percentage of large valve sizes if CT was used for sizing. For example, the 29 millimeter valve chosen in 44% of patients. If CT was used, only 18%. If 3D echo was used, so CT gives you good dimensions of the coronary arteries, of the aortic annulus, to choose the valve correctly. There's a third aspect that is sometimes neglected. I don't understand why, because it's very useful information. By CT, you can determine exactly the projection that will give you an orthogonal view onto the aortic valve plane. You can take this projection into the cath lab, and with the first shot, you will achieve an aortogram that shows you an exactly orthogonal alignment of the aortic valve. A number of publications have shown that this is possible, reliable, and that you can save significant amounts of contrast agent in the cath lab if you look at the CT that was done before to determine the best projection that you can use for your aortograms. So in summary, the three aspects that can and should be analyzed when you do CT prior to the TAVI procedure is to determine the access site and the pathway of getting to the valves, to look at the aortic target region, the target anatomy, aortic annulus, and the dimensions, for example, of the annulus and the distance of the coronary ostia to avoid obstruction, and thirdly, optimal fluoroscopic projection angles, because that can help you save significant amounts of contrast in the cath lab. There has been a very recent randomized trial in 100 patients who compared using CT and not using CT for procedure planning. And the patients were followed for a year. And you can see that the rate of event-free survival in CT was 92%. Event-free meaning no significant paravalvular aortic regurgitation and no death. And the event-free rate was 92% in those who underwent CT-based TAVI, and only 60% in those who underwent TAVI without having a CT performed. So this very clearly shows the advantage of using CT. And with that, thank you very much for your attention.